we're back. Podcast. I don't know what this is. 134 maybe. Anyways, closing up on another good year here with my good buddy here, Dr. Ivo. We've had a great year over at onlinece.com. More listeners, more students than ever. And Ivo's done some good teaching this year. We still have plans for WebEx next year, some seminars that are online, something a little bit different that will get, make us more available to the other folks who don't want to get onto a credentialed online continuing education program. So some other things planned. I'm going to do some videos on my end as well, and Ivo and I are probably going to try and add some other videos and updates to some other things. So anyways, things are up in the air, but we're still moving ahead. We're still here, 9 years going, something like that. Is that right?
Sounds about right.
8, 9, yeah. So a lot of you are coming up to some continuing education credentialing time slots here that you need your hours. And just to remind you, there's probably a couple dozen of our courses over at onlinece.com. You're more than welcome to go over there and just go through our whole catalog and get 20, 30, 40 hours. I'm not even sure how many are there now, maybe more, of courses. So that'll get your license up to date, and the price is right for that stuff. I think it's like $19 or something like that, so it's very reasonable. And there's also some other good lectures over there as well. So I took some neuro classes, and Ivo's got all his acupuncture, right? And
yep, there's all kinds of stuff.
We've got our rehab stuff, all kinds of stuff. So I was in the clinic, and I probably get I don't know who probably gets more of these young kids, but I have a feeling that people don't know when to start with children in terms of gait and reteaching the foot posturing. And we did some articles this week on there was gait and autism, and that was kind of important. That it was kind of an important breakthrough in autism there. They figured that somewhere around 12 months, stronger connections between the brain's motor and something called the default mode network were associated with better walking and gross motor skills. And by 24 months, the brain networks linked to attention and task control also had become engaged in walking and gross motor skills. That's something that we've referred to at least previously as dual tasking, and we've talked about dual tasking and increasing gait errors and targeting errors, and the problems with obviously the elderly as their gait starts to decline, their balance starts to decline, as their neuromotor skills start to decline. Dual tasking, whether that's talking and walking or negotiating an unfamiliar place like walking through a restaurant that they haven't been to before, where they have to kind of step around people and chairs and tables, can be more difficult. But certainly we've seen people walking and texting and walking and talking on their phone, and some of us have probably done the no-nos of texting and driving, or less of an offense of talking on the phone and driving, and you kind of black out. You don't really pay much attention to the motor task of driving, which is obviously very scary, and none of us should be doing that stuff. And so dual tasking is a problem. But when they talked about these children, obviously at the early months there in the first 12 months to 2 years, they can't dual task. These kids are just trying to figure out how to put that foot in front of the other foot. And as this walking improves, it's possible for the child to begin to think about where they want to put their foot. In other words, there's a goal at hand. We go through that cruising phase where the child pulls themselves up and they're walking along a table with their hands on the table, just kind of guiding them for support. But eventually the child starts to venture away from there, learning balance, and then they start aiming for targets instead of cruising around the perimeter of the room or a perimeter of furniture. And in autism, these things seem to be a little bit offset, and these key deficits appear to be a problem in the development of these neurodevelopmental problems, such as autism, as in the case of this article, which was in futurity.org. We'll have it in the show notes for you, but it was also on our social media the second week of December here. So these things are things that we see. I certainly don't see a lot of infants. I tend to see the kids somewhere around 5, 6, 7, 8, and even later, where the parents, often single, first-time parents, my kid's feet are turned out, my kid's feet are collapsing, my kid is toe walking, my kid is bow-legged. and those are all issues that you and I are very comfortable dealing with. We've been doing it for decades now. Do you get a lot of young kids, and where kind of is where do you start tinkering with these things? I tend to say somewhere around 5 or 6 years of age anyways, where the kid is at least cognizant enough and aware enough that they understand what you're talking about. But, one of the dilemmas is that we get into these teenagers, and obviously they're more attentive and more bodily aware, but you've lost some time there. And there's this juggling point in between 5, 6 years of age and 15, 16, or even earlier teens, where there's this, what do you do and how often do you do and how aggressive do you do it? I still have a lot of doctors in the area that are referring patients in on gait-related issues, and they've always asking this question, when is it an appropriate referral and when is it not? I always say, well, it's never a bad referral. I'll tell you if I think it's too soon for the child, but what are your thoughts on this stuff? And do you see, you've got the inside information of having several kids, and so you've seen them go through this, and you've probably played with them more than I have in terms of, personal experience. But what are your thoughts on this stuff, and where do you like to start? And, do you have some rules or limits?
Well, there's a lot of ground there that you just covered. I think that your ballpark figure of 5 is really a good thing to think of, not just with autistic kids in general, but and that's when a lot of things are going to start to come out. But in children in general, according to, we did an article, it was like 5 years ago. It was in Journal of Biomechanics, talking about foot mechanics and development in children. It was like 2011. Anyway, it says that, foot maturation, predominantly looking at the metatarsophalangeal joint biomechanics and things like that, tends to occur right around age 5. And that's interesting because that correlates with brain growth. So a newborn's brain is only about the quarter size of our brain, as you know, and it's going to grow to about 80% of its adult size by age 3 and 90% of its adult size by age 5. So that right around age 5 is really starting to become somewhat more critical from development than before that, because they're just growing at such an exponential rate. Their brains are much more active than adult brains. Physical activity and cerebellar input is, of course, very, very important, because the cerebellum is basically what's going to drive a lot of that balance and coordination system that's going on. So, rather than having your kid do a lot of passive stuff like work on an iPad or watch a movie, giving them a hammer and having them pound on the TV or having them jump off of the TV is probably a much more physically active and better thing for their development as that's going on. So I don't think it's ever too young to look at a kid, but I don't really start to get excited about stuff unless it's a very severe torsion or version, or torsion, I should say, not a version, because versions are normal, until about that age, because all of these things are going on. You're born kind of dink-toed and very, varus in your tibia and everything, and a lot of that stuff starts to change as we have increased skeletal maturity. So if you see some kiddo that's not headed in the right direction by age 3, it's certainly cause for monitoring, as far as looking at, maybe 3 to 6 month intervals, taking some measurements, looking at the amount of tibial torsion that should be decreasing. Remember it. The tibia should rotate outward at about 1.5 degrees per year. Femur should be rotating inward, because we're born somewhat anteverted and with internal tibial torsion as well, and those torsional deficits should disappear as time goes on. So if a kiddo, and we've got an article on this, actually we have many articles on it, but if you go to the blog and you type in something like torsions or development or things like that, that will bring up some of these articles, but it'll bring up, more importantly, some of the charts that look at the standard deviations of what it is. So when a kid is outside of 2 standard deviations of where we normally like to see them, those are the kids that my radar goes up and says, we want to monitor this. As far as what's going on, let's see them every 3 months, let's see them every 6 months. And then educating the parents or whoever on, what's supposed to happen developmentally, kind of what we're looking for. Now, you got to be real careful, and you've pointed this out many times when we teach. you can't push a kid too hard too fast, because then you're going to lose some of those developmental windows that we always talk about. And if you miss a developmental window, that's going to create other problems, with what's going on. So I would say, most kids are probably walking by around a year old, give or take probably 3 months, depending, guys walk later than women do, that kind of stuff. But you're really not going to start to see some of that maturity with the foot or the nervous system till right around age 5. And of course, spotting things earlier is always good. Perinatal development is very important, and prenatal, as far as, having a good diet. And, do you exercise? Did you get enough omega-3s in your diet? Are you eating green leafy vegetables? All of those things need to feed in, because that's ultimately what's going to help to determine brain development in the kiddos. And if those things are missing or lacking, or you're a smoker, or you do a lot of caffeine, or you drink a lot, or you smoke a lot of pot or whatever, then developmentally that's going to affect what's going on with that kiddo. I don't see a ton of kids, because like you, we've got a reputation, where I practice of like, well, these are the guys for foot stuff, and leg stuff and gait stuff. We have a tendency to see some of that stuff that's referred in. But, a lot of times with guidance and reassurance, things kind of get better on their own, either, because of you or in spite of you. And then there are those cases where you kind of need to monitor. We had a case I can remember, and I know you know the one I'm talking about. It's on the Tumblr blog, and I believe it might have been transferred over. But we just followed this kid serially. He was brought in. He had moderate genu valgus. He had moderate internal tibial torsion, and he had moderate femoral antitorsion. And we were just monitoring him over time, every 6 months or so, and we'd see him, and we'd kind of give an update on the blog. So I don't know if that answered the question at all.
Oh, yeah.
But catching some of this stuff, earlier is obviously better. But as we start to walk and move, we activate larger parts of our brain and our cerebellum, and that, of course, is going to in turn feed development. So anyway, that's kind of what we do. On one note, though, you put up a great post on our social feed, as well as on our blog. But if you look on the social feed, it was out of Futurity. It says how babies learn to walk holds potential clues to autism. With that particular one, there's just beautiful picture of a kid's feet. And a couple things that you notice right off the bat looking at the feet, besides one, they're kind of chubby, and two, they don't obviously have very good quadratus plantae development yet at that phase. But you can see that extensor hallucis brevis is really engaged, particularly in this kiddo's left foot, but bilaterally. And that's important, because as you're learning to walk and you're cruising around on furniture and things like that, you really need to get the head of that first ray down. And because that's going to help create some stability of that foot, or whether you want to call it the tripod, the tetrapod, the multi-layer of what's going on. The other thing, because this child in the picture is weight-bearing predominantly on the right-hand side, you do see increased flexor tone, which is not pathological at this age, of what's going on, and that's because he's standing on one foot and he needs to try to regain stability as well. But interestingly enough, you can still see that dorsiflexion of the first metatarsophalangeal joint, or the big toe joint, trying to get that head of the first down to create some degree of stability. So just kind of a neat picture. If you look on the blog, there was, I think we did a post a long time ago when my kiddo was just learning how to walk, about the extensor hallucis brevis, and I got a similar picture of his foot. Somehow we just lose that. I don't know if it's shoes that we wear, if it's flat planar surfaces that we're walking on, but we really kind of lose that extensor hallucis brevis and proneus longus function to get that first ray down. And, maybe that's a function of our ontogeny and just normal development, or maybe it's a function of, what our environment is presenting to us, and more of epigenetics, so certain things get expressed because that's how we're taught to express them.
Yeah, probably a combination of a bunch of those things for sure, but it is interesting how that gets lost. And, certainly footwear is suspect, right?
Oh, yeah.
Yeah.
And we always encourage people like, hey, don't have your kids in shoes.
Yeah.
Have your kid walking around barefoot, that kind of stuff.
Yeah.
Just because it's so important.
I'm sorry, I didn't mean to cut you off if you had something else.
No, I mean, the only other thing, and I think you mentioned this, is just talking about, out of the article that they were talking about, is when you have a slowness of motor development, and we've written on this plenty of times on the blog, when we have that slowness of motor development and function, kids are more likely to have problems like autism and other stuff. So if there's that delay to walk or that learn to walk or that discoordination, and that's not occurring during that sort of expected developmental window, then they're more likely to have a problem.
Mm-hmm. And I suppose it would make sense that, getting the kid walking could be a little bit of a mitigator against that. But, I do remember, and boy, this could be really old information. I'm sure you know it, and you can either dismiss it and as fact or fiction, who knows. But, about too much stimulation in the developing brain can create some problems too, right? If they're not ready to, if they don't have all those cross linkages and the synaptic, connections, that forcing the child too quickly can cause some problems too, right?
Mm-hmm. Yeah.
Yeah. Someone at some point had called that burnout or burning it out or something like that. I don't remember. I think it was when I was back in school, so it was decades ago. But they talked about not having a child, having them on their back and moving into cross crawl patterns, non-volitionally, in other words, induced by the parent. That should be something that the child does. But it was always an interesting thought. Well, could you get this kid to create some linkages quicker than normal if you stimulate those things? But things are supposed to occur in a time-wise fashion, which is the principle of DNS, the developmental neuromusculoskeletal stuff, which is Collage's work over in Prague. Things are supposed to occur at certain time frames, 3 months, 6 months, 9 months, 12 months, and there's these different patterns of rolling over and turning and crawling, and then kneeling and then getting up and cruising and walking, etc. Is there something valid in that, in pushing those patterns too quickly, that you could get those windows to either close up too quickly or to express themselves before the child is ready to? I mean, almost the opposite of the autism spectrum disorder, where things are happening too quickly?
I've never seen that, and I haven't read about that, but that doesn't mean that that's not the case.
Yeah.
As far as that goes, I think that children are way more capable of a lot of things that we, place demands on them. Perfect example is I've got two sons. I watched the first one develop, and then the second one developed way faster because he had a model,
sure,
to look at.
Yeah.
And motor development, all that thing was on an accelerated scale, as far as that goes. So I think you can only push the system as fast as it's willing to be pushed.
Mm-hmm. Okay.
It would be interesting to look at that and see, gee, is there a decreased incidence of, X with, pushing that motor development? There's a bunch of work that looks at more cognitive and intelligence work that looks at all of this prenatal stimulation. I can't remember the name of the individual off the top of my head right now, but where you do a lot of this stimulation stuff with your kids. You play music for them. You use these black and white flashcards with them with certain designs and patterns. You get them to work on tracking with their eyes and things like that. And supposedly, when you do some of these things, the kids are somewhat more intelligent. So is that a function of what you did, or is that just a function of your paying more attention to your kid and spending more time with them, and they're smarter because you spent more time with them?
Mm-hmm.
Tough to say, as far as that goes, but interesting concept.
Mm-hmm.
I think I have one autistic patient that I work with now on a regular, quasi-regular basis, and then another one on a less regular basis. And just with simple things like improving cross-crawl patterning, simple marching exercise. So can they coordinate their right arm with their left foot? And if they can do that, can you coordinate head rotation? And we start with crawling, kind of like what we've done at your office before, with people, having them tie a string from, one knee to the opposite hand on both sides, so it's crisscrossed. And then as they bring their hand forward, the foot goes forward, and have them either rotate their head to that side or the opposite side, depending if we're trying to get more upper or lower extremity. Basically taking advantage of some of those primitive reflexes, which many people say, oh, that's pathological. They're not supposed to be present. They don't persist, into adulthood and things like that. Otherwise, it's abnormal. And I would have to say that I respectfully disagree looking at Bobat's work and a lot of other people that have done that stuff. You can certainly take advantage of those things. I can stick an EMG needle in your arm or your leg, and I can turn your head to the side or have you move your eyes with the cervical ocular reflex, and I can get increased motor activity unilateral, with extension on one side or flexors on the opposite side of head rotation. So there is some persistence of some of that, and taking advantage, and I know you do this too, of those neurological reflexes when you're working on people can make a difference. And I think that with these kiddos, and that's the point I was trying to make, you can make a fairly large distance. I don't know if you remember the gal that we talked about. We've done her on online CE. She has tetrasomy 18. Mm-hmm. We talked about her. There's only, I don't know how many cases, not many, in the world. We had the opportunity to see this gal, and just working with her very intermittently, like every 3 months, giving them activities and patterning things to do with the mom. I mean, you could see, and we have the video that we show on the online CE course that we do, just pre and post. It's like, wow, I mean, it's pretty dramatic stuff. And there's no reason you can't see changes in these kids that have ASD, autism spectrum disorder as well, and also ensuring they have a good diet, and a good environment and all that other stuff.
Interesting. The dialogue brought up, way back when they used to take these kids with these torsional deformities or bow-leggedness or significant internal external tibial torsion or femoral torsions, and they used to put them in the braces to try and reduce that. I've not kept up on that stuff just because I don't see the extremes of those, but it makes me wonder. Do you see those extremes in your office, by the way? Before I go on, do you see?
I don't.
Yeah.
I don't.
Yeah.
But you have to wonder: does it screw the kids up?
Yeah, that's
because you're cutting down on motor activity. Yeah.
Yeah. Does it screw them up? And how many times do these kids actually just self-correct, just given the right amount of time, and as they start to move more? Like you said, you put these kids in these braces and stuff, and now you're actually limiting motion, and so without the motion and the motor, the sensory motor integration, you're not going to get some of the natural reduction process. So you may be actually putting the brakes on the normal derotation process, which we know occurs. So we talk about that in some of our online CE courses, the normal angles as the child progresses age-wise. So. But, people just don't seem to be doing that anymore. I think that's advancements in medicine, realizing that a lot of these kids come out okay. But, it's one of the things that it's probably the most frequent thing that parents bring their kids in for, at least the young children, 5, 6, 7, 8, is these torsional issues that are obvious, maybe on one side. And, it makes you wonder, how many of these things were overtreated or... just sometimes benign neglect, as we like to say, is never a bad thing as long as the child doesn't get worse and does show some progression. So, I continue to see those maybe a couple of months where parents bring in the kid and said, look, what should we do about this? And a lot of times the answer is just nothing. Maybe we design some gait games, along a 2x4 or something where the kid has to walk a little bit and just start cueing some better foot alignment a little bit. But it's more about educating the parent and trying to decrease their anxiety about it than anything else. I think you probably agree with that, right?
Yeah, walk barefoot, eat more green leafy vegetables, play a lot of games, get outside and move.
Yeah, get the kid.
Those are the biggest things, and any kind of balance and coordination activity.
Yeah.
A lot of kids are amazing rock climbers. Like, I go to the rock gym and stuff like that, and you watch some of these kids, and they're young kids, and they're just smoking my shorts, because it just accelerates, motor development as well as other stuff as well. So get him doing stuff, whatever that is, whether it's using a bike with no pedals or whether it's outside crawling around in the dirt, or climbing on the jungle gym or whatever, but just really pushing activity. And I think that's just important for neural development, particularly cerebellar development. And we know that cerebellum is integral to learning. So I think that the kids that are active and do that stuff and have the substrate to support that actually are smarter,
Yeah, we've talked a lot. We've written several articles on rock climbing over the years here and how that tends to tap into that quadrupedal pattern, which we don't tend to get into much anymore. Children do it and then they get away from it, and we just don't get down on the mats anymore. Being in jiu-jitsu now for little over 5 years, there's the majority of what we do is on the mats. So you learn how to crawl, you learn how to negotiate a lot of these positions, and it's very interesting to watch some of the newer DNS collage type exercises that are being shown online, and how many of them look like, I hate to say it, but kind of rip-offs of jiu-jitsu warm-ups and jiu-jitsu movements. The Turkish get-up and a lot of the seated hip hinges and stuff like that, or the kneeling hip hinges and tall kneeling and all of these things. And it's very interesting to see how many of these things are just natural movements that occur when you get down on the mat and you start moving around, particularly when you're playing around with someone else. And in jiu-jitsu's case, you're rolling around and trying to, create positions of advantage. And it's just really interesting to see. The first few weeks were very entertaining to me because you had to go through forward rolls and back rolls and learning how to fall and shoulder roll and bear crawling positions. And I'm like, God, I can't remember the last time I got down on my hands and knees and moved like this. It was grade school for a lot of people. And now it's just second nature. And it's interesting that I think it does something to you physically to be able to get down on a mat and get back up. I mean, how many people can't get down onto the mat and get up off the floor without their hands? At some point in the last year or two, there was something on the internet saying it was highly predictive of, increase of falls or decreased age, where, if you couldn't get up and down off the floor without using your hands, that the likelihood of some early demise from falling or what have you, especially as an elderly person, increased. But the rock climbing is really the same thing. And I think it's great. And I'm glad you brought it up. It's something that's actually on my to-do list. We've got a great rock climbing couple of them here in the Midwest, right in the Chicagoland area, where you're going through a lot of these quadrupedal patterns, loading and unloading. And, it's interesting stuff. And it reminds me, since we're on that topic, of, something that you brought to mind, and I still see it being kind of glazed over for some reason, about the bird dog, where it's just not a natural pattern, right?
Yeah, not at all.
And we talked about that bird dog is still one of these primary lumbar stabilization patterns, but it's you've got one leg going out and the opposite leg going out. You got one leg moving into extension, the other leg moving into flexion. That's not a normal pattern, right?
Yeah, when you have one leg in extension and the contralateral arms in extension, that just never occurs.
Yeah.
In the gait world, even when you're crawling, it doesn't occur.
Mm-hmm.
So we just, we've obviously posted on that before.
Yeah.
There's probably time to do a rerun on that.
Yeah, I think so.
As far as that, we can just do that and some of the neurological reflex stuff. But yeah, it's I don't teach it because it's not neurologically congruent.
Yeah, I don't either.
And when you present it that way, and I obviously teach a lot, and so do you, and you got a room full of physicians or PTs or whatever, you start to get a lot of stuff. And then when you start taking them through the neurological pathway, and I'm like, okay, so show me how this is neurologically congruent with what you're trying to accomplish.
Mm-hmm. Yeah.
And nobody can because it's not.
Yeah, it's simple.
So I'm not saying you shouldn't ever do it. I'm just saying that it's not, an exercise that I think should be at the top of your list. As far as that goes. But, there's no papers to support that.
Of course
so not. You can make the argument that, well, there's no paper that says that this is more efficacious
right.
Than the other one.
Yeah.
So.
And why should we?
Somebody out there who wants a project, write a paper, we'll help you.
Yeah.
All right.
Yeah.
And then we can get out and we'll know the truth then.
That's right. Yeah, because we're just two crazy chiropractors, don't know what we're talking about. So it's, why should you listen to us, right? Yeah. So, one of the other posts we put up this week was interesting things that we've talked about way back when, probably around podcast number 30 or 40. This one was in Newsweek, and it was talking about the 1.5 million year ago growth spurt helped us to grow taller and lankier. Brought up a lot of things, including the thing that I had forgotten about, but we talked about it, that persistent hunting and humans, because we can sweat and we don't have a lot of hair on us, we can dissipate a lot of the body core temperature, which is why the animals tend to not be such good endurance runners, which is why we can chase these things down over a period of hours, and they fatigue just out of sheer exhaustion and heat exhaustion, whereas we can keep going. But this article was out of Newsweek, and they were talking, it was some work from the author out of Cambridge, Manuel Will, and this was at physiology.org website, and they were talking about Homo species. We left the forest to move more into the African savannas. And we talked about this. I'm trying to name the name of the book. Scars of Evolution. That's what it was. We talked about that in the early podcasts. And Radiolab talked about it a little bit too. Just really interesting that there was this huge growth spurt, and it allowed us to look over the grasses a little bit more, and allowed us to be more bipedal, or at least more effectively bipedal, which allowed us to then carry things with our hands, including spears and children and food, and allowed us to be more mobile in the hunt and be more effective in the hunt. It's just interesting to find that the time frame was 1.5 million years ago. It was this huge growth spurt. Just thought it was interesting. But as soon as you make those changes, all of a sudden the person's gait is going to change. So it makes sense that not only was there growth change, but there had to be a gait change. And whenever you move from quadrupedal to more bipedal, you're going to get those torsional or derotational things kicking in that we talked about earlier in the podcast.
Right. Well, one other interesting thing just on that article, and that's just because this is my thing.
Yeah.
Looking at the three femurs, if you're looking at the picture, they're heads of femurs, and it goes from oldest to newest, top to bottom. And I don't know if anybody else picked this up, but the two older femurs are more anteverted than the newest femur.
Yeah.
So is that an indication that we've become more retroverted as time has gone on? And I don't know the answer to that. I have to say that you see a lot more people with femoral retrotorsion or retroversion, so they have less internal rotation due to femoral acetabular conditions, as well as the angle of the head or the neck of the femur with the shaft. And that's just something I always look at, when I'm looking at skeletons, looking at the degree of that. And maybe it just happens to be the bones that they picked, as far as that goes. But that was just another sort of, it kind of makes you think.
Yeah, we'll have that one in the show notes so you can look at these femurs that I've mentioned here. I did notice that, but I didn't look at the old to new. I wasn't correlating those, so that was a good call on your part. So we've got some more stuff.
Well, I don't know if it's...
Go ahead.
I don't know if that's good or bad, but that's just kind of how it is.
Yeah.
We've done enough posts. Gosh, if you want to go back for a good laugh, go to the Tumblr blog and type in torsion. We've got pictures of velociraptors. We've got pictures of elephant butts, all sorts of things. Just from, these are when I'm looking at I'm in a museum. We go to the Museum of Science in Denver a lot. I'm always looking at skeletons, and I'm always looking at bone structure, and I'm trying to figure out how that relates to how that particular animal moved, and things like that. And elephants, I'll let you look for yourself, but you can see their femurs. They definitely have some serious torsional things going on there. But that just is a function of, how their hips develop, whether they're ornithischian or saurischian, depending upon the hip development. So they're lizard hips or they're bird hips, if you believe that we descended or developed from dinosaurs or evolved or something like that. But anyway, interesting stuff. Sorry, got off track there.
No, some people don't believe in that, but some people also believe that the earth is flat, so to each their own, I suppose.
Right. You mean it's not? I know. I live where it's proof that it's not flat because there's lots of hills here.
Yes.
And we go up and down them all the time. It just, the way you go up and down them just changes. Hey, you put up this other post this week, and thank you again for covering the week. It was good. This one on high-intensity exercise curbing Parkinson's disease. It was just really neat to see that. We have a good number of Parkinson's and, more people along the Parkinson's spectrum disorder, we'll call it, because a lot of times now we're finding out it's not just that, typical presentation that you're seeing. You're seeing a lot of atypical or, different sorts of presentations of people that have Parkinsonisms. So it was neat to see one that this one, and I hadn't actually, this doesn't surprise me at all, but I hadn't actually seen or heard this particular study about it's going to be slowed disease progression. We see lots of stuff with diet. You see lots of stuff with cognitive activity, things like that. But it was nice to see that we knew that exercise could mitigate the symptoms, but I wasn't aware that it could actually slow the progression. So,
yeah, interesting. And neurodegenerative. So we're talking Parkinson's, Alzheimer's, dementia, all of those things. And it was, like you said, this wasn't earth-shattering. And one of the researchers said, hey, is there any disease or any disorder for which exercise is not good? I mean, you're going to be pretty hard-pressed to find one. But it was nice to see that once again, you could actually take a neurodegenerative disease here. I'm seeming to have some problems talking today. I don't know what the hell's going on. Maybe I've got a neurodegenerative disease. That they actually found that not only does it slow the progression, but it actually might change the long-term morbidity of this thing. So that's interesting. That's huge, because all we are is looking for drugs these days, but maybe it's just as simple as get out and move more. One post that I've been meaning to put up and meaning to finish, and I just haven't, was how these neurodegenerative disorders are they're just fascinating to me. These movement disorders. There was a classic case, and I've got a video of it. It's online. You can find it. But this guy, he's clearly a late stage Parkinsonian gait, where he's got the shuffling walk, the stuttering. He's clearly, almost into a freezing gait type presentation. And then they get him up on a bike, and the guy's riding up and down the street like there's nothing wrong. He's smiling, he's moving, and it's just like,
I've seen that video.
Yeah, it's so cool that wait a minute. He doesn't have a gait pattern, but he can ride a bike, which was a pattern he developed when he was younger. But it's a completely different, I guess, neural pathway that just doesn't have the limitation because of all of the nuanced components of the Parkinsonian, some of which are visual, right? I remember they showed that in the that Oliver Sacks film with Robin Williams, where they were on the checkered floor, and he suddenly realized, oh, it's the floor that's screwing this guy up. So, do you know anything about that pattern? Because I haven't gone into that one with the guy riding the bike all of a sudden, but is it just a different motor program, or is it because that motor program was developed earlier on in life before this new one started decomposing?
My best hypothesis for that, because I don't have an exact answer, I don't think there is an exact answer, but I think is that with Parkinson's we have degeneration of the nigiostriatal pathway. In other words, the substantia nigra, the pathway that communicates with the basal ganglia, starts to break down, and we get insufficient dopamine secretion, and we develop all of this stuff. When you're riding a bike, there's a much larger vestibular component that occurs there, and our vestibular system, if we remember correctly, feeds a lot of what happens with our axial extensors and drives a lot of the motor and coordination system. So if we engage that to a higher degree, such as with a pattern activity like cycling, it's going to dampen down some of the other things. Now, Parkinson's people fall a lot, but they fall a lot because their motor reactions aren't fast enough. As far as like if they're starting to tip or something like that, because they just don't have that. When you're riding a bike, you're engaging a different portion of the brain, which is assisting with that. Plus, not only do you have the semicircular canal component of the vestibular system, which does angular accelerations and things like that and rotation, but you also are engaging the utricle and the saccule, which are the portions which do linear acceleration with that. And I think because the vestibular system largely it's going to feed directly into the flocculonodular lobe of the cerebellum, and then that information is going to come back out, and that's going to drive, one, eye movement, but also, two, it's going to drive your vestibulospinal system, via the lateral vestibulospinal tract or the lateral vestibular nucleus. So I think that's the main reason, is because you're improving that component. So it of course begs to differ. It's like, well, it's well known that proprioceptory exercises generally improve Parkinsonian symptoms. So why not up the ante? I mean, riding a bike is just a propriosensory exercise. You're just making the balance component that much different. and perhaps some of the visual input that you're getting, because you're changing that and you're doing it at a much more rapid rate, is making a bigger difference. That's my hypothesis. I don't know if that's true. Maybe it's just, not. But
well, it seems reasonable. Over the years, I had put in someone, it was in a lecture, it might have been a Dr. Carrick lecture or a Dr. Malillo or Powers lecture at some point, where they said that, you need to ask your clients in their intake, did they ever learn how to ride a bike? Because if in what stage you learned it at, did you learn at a younger age or was it older age? And if you didn't, you should know. And it's funny because over the years, occasionally there's been the client that will check off the box saying, no, I don't know how to ride a bike. It's not many people, of course, but these people I have noticed have an interesting gait, and they've got some funky balance issues. They just don't seem to be these very stable people. They seem a little bit more fragile, and I don't know if that's something I wanted to see. I don't think so, but these clients were harder to rehab and fix and help, because as you just went through, they haven't developed some of these pathways that are absolutely critical. And I think it's largely, and you can correct me if I'm wrong, why once you've ridden a bike, it doesn't take more than a second or two to get back up on it, even if it's been 20 or 30 years. That pathway is just burned in there so deeply in your childhood years that, it's just get back up on the horse and you start going again.
It's just another reason more people should ride bikes.
Yeah, absolutely.
So go to the rock gym, get out your mountain bike. That's my answer. That's my rehab.
So this last one we put up, I happened to get it from the neurology forums and borrowed it from them because I thought it was important, and it was on spinal cord and your spine, when your spinal cord takes charge. This one's probably right up your alley, but it was on basically spinal cord reflexes and the inhibitory processes that occur that allow people to retrain and correct their gait. And we, as I said in the post, that it's important for us all to understand these concepts, because there are those people out there that are retraining people's gait just off of visual. And there happens to be a very prominent gait specialist, as this person puts themselves out there to be here in the Midwest. And one of my clients recently went to see them, and they were coaching arm swing in their son, and they didn't get any better, and so they brought their son to me, and I said, well, I would never coach arm swing as a starting point. And then I corrected myself, say, well, I'm never going to say never. There are certain instances where I could maybe make a case that maybe they had aberrant arm swing because they had a rotator cuff problem, or a strain of some sort in the shoulder, and they didn't want to create some arm motion, so that it was inhibiting the normal pendular swinging of the arm. But as we know, there's an effect on the opposite lower limb. And lo and behold, I examined the kid, and he's got a deficit in ankle plantar flexion on the lower limb on the opposite side of the arm swing side that the coach was recoaching arm swing in this runner. And I said, look, you can coach that all day long, but the reason it didn't change is because it's not the problem. And we've mentioned previously that, that suspect, maybe even beyond suspect, that the upper motor neuron or the upper limb patterns are subservient to the lower limb as a driver. And then there was this article that came up with the spinal cord reflexes and this whole inhibitory process, and these specific neurons called the ROR beta interneurons inhibiting the transmission of potentially disruptive sensory information during walking in order to promote a fluid gait. Did you get to this one by any chance?
I did not read the complete study.
Okay.
But what we're talking about really reminds me of something Dr. Carrick used to talk about all the time, and that's what we call, or a word that I think he coined it's called the central integrative state. In other words, what is the state of the neuron in question? And this particular study looks at interneurons called ROR betas, which are basically gating neurons. So you have information, all this information coming in, some is excitatory, some is inhibitory, acting on neurons, largely interneurons in the spinal cord. Remember that interneurons are 30 times more numerous than like alpha motor neurons and things like that. And what you're looking at is the sum total of all of these interactions gives you either a plus or a minus. So it's either going to fire or not fire. And these guys are some of the ones which are involved with gating or with determining, whether that's going to occur or not. You have excitatory neurons, you have inhibitory neurons, you have interneurons, which can affect both. You have collaterals of neurons which come back and can stimulate other neurons or inhibit other neurons depending upon which receptors they're happening to activate. So cool stuff. I'm surprised from the picture that you didn't talk about her crossover gait, though, because the gal in the picture obviously has a crossover gait that we can see as she's coming across there. So I was a little surprised that you didn't comment on that.
Yeah, well, it was, and I can see it now. I just thought it was weird with the white lines that they have in the picture here. Of course, this will be in the show notes. This was in Neuroscience News this week, middle of December here. But they talked about the whole gating inhibitory pathway, and it's about trying to, I guess, blot out some of the noise in some respects too, right? So that the pattern is a little bit more.
It smooths it out.
Smooths it out, right? Yeah, that's the wording I was looking for. So very cool stuff, and so a lot of the stuff that you and I talk about here, once again, folks, this is not us just throwing stuff around. There are reasons, and a lot of it is neurologic. Almost all of this is neurologic. It's why I've enjoyed doing this podcast. 134 of these now with you is because so much of this gait stuff is just all predicated off of these neurologic pathways and the windows that we close and open up as a child and developing these patterns. And then, of course, as they start to decompose as we get older. So I always find it very interesting that the gait of a young child is not all that different than the gait of a decomposing gait of an elderly person. You see a lot of the same types of peeling back patterns in terms of neurodevelopment. It's kind of sad to see, but I was over having lunch yesterday, and there was this guy. He was probably in his mid-40s, and he clearly had a stroke, and he was really struggling with a cane. And I just thank my stars every day that I don't have these types of gait patterns. But it's everywhere once you start looking, and if you're not noticing gait stuff, it's probably because you're not looking for it. I had this guy that came in yesterday, and he found me on our website. He's been searching for years for answers to his gait problems, and he came in because he had painful bunions for years. Had one side corrected, and then the other side froze up, and he doesn't have any dorsiflexion. And he's been to many gait people, and this guy came into my office, and I did something I don't usually do. I went back to the room first because he said he had to go to the restroom. So he sat on, by the time he came into the room, he sat on the table. I hadn't seen him walk. And he says, I've got a gait problem. Because usually what I like to do is I like to, point them to the back of the office where my room is. And I said, just go ahead down there. I'll be with you in just a moment. Take off your shoes, make yourself comfortable. Because I want to see their gait without them thinking they're being watched. Because in a lot of your clients, probably yours say the same thing, that, when you ask them to walk, they're like, I just feel nervous. And they try and give you their best gait, not their normal gait. Well, this guy didn't look at his gait this time. And I said, well, we'll look at your gait in a little bit. And I started examining him. And clearly he's got a post-surgical bunion and a semi-rigid hallux rigidus on the one side. And the other side is pretty rigid. He maybe had 25, 30 degrees of dorsiflexion. And I was like, I really don't understand why you might be having so many gait problems. And I take the guy out into the hallway, and holy mother of God, this was not a gait problem from his toes. This guy had, I had to pull Dr. Fonda out to say, look, this is a central decomposing gait, is it not? He almost had like a choreiform type gait process. And he thought it was because his feet were rigid. And I finally examined him, and his reflexes were 3+ in all limbs, particularly the lower limbs. There was a little bit of clonus. There was increased rigidity. His joint position sense, where you kind of, for you folks who aren't into the neuro stuff, and I'm certainly on the light side of it, where you trace the heel of one foot down the shin of another just to kind of see how their coordinated patterns are. And he was just all over the place. And I started noticing that there was a little bit of a tremor in his jaw, and I had him do finger to nose pointing, and there was a little bit of past pointing. He was missing the nose a little bit. And I said, do you notice you have a tremor? He says, well, I've had this light tremor since I was 14, and I don't think it's appreciably worse. And this was just one of those cases where just more stuff started coming up. And, he'd said, whenever I start walking, I start getting really hot right away. And it takes me a while to warm up walking, and then I'm pretty good. But when I start walking quicker, I usually start to tumble and fall forward, and I have to be careful. But I do better when I'm running. I had him take off his shirt, and he had all these psoriatic lesions on his back that he was completely not aware of at all. And I said, "What'd your wife think of these?" And he goes, "She's never mentioned it." I'm thinking, oh my Lord. But anyways, really super nice guy. Used to be a very, very good runner. And it was classic early decomposing gait from some type of a neurologic problem. So I got to send him out. But it was somewhere between a choreiform type spastic limb gait and something that looked like almost like a stenotic type gait, where he just, it would almost look like he couldn't feel his feet. He was doing this kind of high step stompage gait, but it got worse as he walked quicker. So I don't know what I was dealing with there, but it was clearly a neurologic based gait. And so I'm going to send him out. But one of these things is, it was just kind of shocked that he'd been hunting this thing down since 2010 because he thought it was a foot problem. And it was clearly just the early progression of some type of a neurologic decomposition or decomposing gait problem. So, but anyways, I don't know if you got any comments on that, but interesting stuff walks into the office all the time. And I'm sure you see that stuff too.
There is lots of pathology out there, and you need to recognize what expected or normal looks like first. And when you understand that, then you're going to understand pathology is going to jump out and bite you in the nose. But you really have to look at and we have a tremendous amount of normal or characteristic or expected out there. So if you start looking at all of the obvious initially, then the less than obvious is going to really have a tendency to jump out with that. And, this guy's probably had this thing cooking for years. Yeah.
It was kind of like that chronic demyelinating polyneuropathy that I had, where it was just slowly cooking on until one day he came in and it just had kind of tipped over the edge into this new realm of gait decomposition, and it was clear at that point that it was a neurologic gait, and it was time to get the referral out there. But sometimes things are light and soft at the beginning. You don't notice them. The client's clearly having some problems here, but you're in your 60s, you're in your 70s, you haven't been active, and you're just starting up again, and you've had a lot of sprained ankles, you got terrible feet, and it's easy to write some of these things off. But this one, I was just shocked that he'd been under care for some other people, and it was clearly not a case that needed to be written off. And it was a little disappointing that this poor fellow was struggling with this all the time and not understanding why. Everybody was saying, "What's wrong with your walking?" And he says, just because I have painful feet and toes, and I got rigid toes. And I'm like, oh my God, So that was a little disappointing and sad news to have to sit down with this guy and go, this has nothing to do with your feet, man. There's something else going on, and I got to break some bad news to you. There's something that we need to pursue here pretty quickly here to see what the heck's going on. But he was very appreciative. I mean, he was sad, but he said, look, I got to be honest. I had a suspicion that this just wasn't all my feet, but, nothing else made sense. And if you don't know something exists, you don't know to consider it. And I said, well, I'm sorry to be the bearer of bad news, but there's something else going on here, and it's not your feet. Right. So, yeah. All right. Well, there's an hour again. It's amazing. Yep, just a little bit of talking. It does. All right. Well, this might be the last podcast you folks hear before the end of the year, by the time we launch this thing up. So we wanted to thank you for hanging out with us for the last 12 months and the last 8 or 9 years. And we're going to be back next year for some more fun with you guys, more interesting stuff, and looking at the research and trying to keep you guys ahead of the pack here. So I wanted to thank you for your time. It's valuable, and an hour of our talk in your ears is time of yours, and hopefully it's valuable to you, and hopefully we saved you a little bit of research and time and given you some things to think about. So I guess that's it. Sean Allen here in Chicago, unless you've got anything else you want to add, Ivo.
Ivo Warlup, Dillon, Colorado. We will see you in the shoe aisle.